And to all of you online and those watching the recording, thanks for giving me a little bit of your time. I'm going to cover a few of the resources that EveryLife Foundation offers for patient advocacy organizations and individual, rare disease advocates. Focus on a couple of the projects of late that are really trying to drive the evidence base and tools to help improve the diagnosis, treatment, and access to care for people with rare diseases. And for some of you, I recognize some familiar names, and this may not be new, and I welcome your questions. This is a little bit of an overview, but I'm happy to dive deeper on anything. So please, enter your questions during chat, and we'll be happy to address things that aren't on this presentation as well. So for those of you who aren't familiar with the EveryLife Foundation, we're a 501c3 patient advocacy group, and our mission is really to empower the rare disease patient community to advocate for impactful science-driven legislation and policy that advances equitable development of and access to life-saving diagnosis, treatment, and cures. We really pride ourselves on the fact that we, try not to speak for patients, but provide the training and the resources and the opportunities to help amplify your voices as well. So with that, just a little bit of a preview of our general policy goals. So we know that 93, probably 95% of rare diseases have no FDA approved therapy. And that is really a main focus of underpinning all of our efforts. So we want to close that innovation gap. We then want to eliminate the diagnostic Odyssey for rare disease patients. And I know that that's what many of you are focused on as well. Improve the regulatory process. You'll see that throughout our resources and our policy efforts, and advance regulatory science for rare disease therapies, and ensuring then probably the most recent addition to our mission and policy goals is really making sure that those therapies that are approved are able to be accessed, and that we don't put up unnecessary barriers. That the worst thing is to have a treatment and not be able to access it after all of the dedication and years that are put into it by groups like yours and others, and we want to make sure that we're making, getting that benefit to patients. And then lastly, just empowering patients to develop that impactful voice in policymaking, drug development, and regulatory decision making. So I don't need to repeat this for you all. You know the statistics better than most. It's just we really want to stress, and you'll see how we go about solving some of this in the next presentation and the next slide, sorry, that rare disease is a public health crisis. Rare is not rare, that it requires solutions to match our unmet need and the urgency. And we'll dive into some of these statistics. So, the first project I wanted to cover was the National Economic Burden of Rare Disease Study. It's a timely mention because while we did have the preliminary results and some resources out last year, the full peer-reviewed publication was just published yesterday in Orphanet. So we're excited to see that publication get out there and into the research literature. But really this study was spurred by our community Congress and the fact that by and large, we don't have the data that we need to make good policy decisions, good clinical decisions, and it just echoes from there. So we are really trying to solve the challenge of not having data to drive good policy and drive more attention to the rare disease needs. So this is a problem our economic burden study was addressing. So this study, ultimately, this is a little bit of a summary, we'll dive into it a little bit more, but ultimately we released again the preliminary results last year and found that of the 379 rare diseases that we could track in this study, that the total economic burden in 2019, so this is pre-pandemic and really just the tip of the iceberg, that it was 966 billion, so nearly $1 trillion. And again, that doesn't even touch the surface of the number of rare diseases because we were only able to actually track and pull the data for 379. And that is will feed into another topic we'll talk about around ICD codes. So what did this burden look like? I think importantly, most important is that much of this cost is shouldered by families, and the direct medical costs were 418 billion. So just, a little under half was for medical costs. And of those medical costs, you see, maybe surprising, maybe not, that the inpatient costs were really the biggest cost driver in the medical side, and that RX meds, outpatient, therapy administration, despite a lot of the narrative around that being the main cost driver of healthcare costs, in rare diseases where we don't have the luxury of having approved treatments for many of them, it's really that inpatient management that's driving the medical costs. But again, the large majority were shouldered by families, employers, and others because they are indirect costs, productivity losses, forced retirement. I know many call it early retirement, but that makes it sound like a luxury, and it's not in this case. It's forced retirement, lost productivity at the workplace, and then a huge burden of non-medical and uncovered healthcare costs that rare disease families have to shoulder: home modifications, transportation, auto modifications. And I know I'm preaching to the choir here, but that we really needed this data to highlight to policymakers what are those drivers. What if we don't understand the problems we're solving for, we're going to create bad solutions. So this is really was our impetus to do this work. And then a couple of other highlights beyond the economic burden. We looked at what's the medical burden, what's the diagnostic Odyssey look like, and through that survey we found the average time since first rare disease symptom, the mean was 16.5 years until diagnosis, and that it took at least 6.3 years, navigating that process of purposely trying to get a diagnosis. So there's a discrepancy there as people go back and recall, like, when was my first symptom, to then going and actually navigating the process of getting a diagnosis, and that alone reported an average of 6.3 years. We know this is an issue we can do better, and we have to do better on. And then just to wrap up the burden study, special thank you. This study was driven by the community the whole way. It was a hybrid of a claims analysis, really robust, data analysis, as well as the rare disease impact survey, which so many of you might, filled out, and really it took some time. We asked people to come to the computer with their 2019 financial records and input real data on how the costs of rare disease were affecting them. And so we are just so appreciative for the community and the study sponsors, and everything is listed on burdenstudy.org, and I can drop that link in the chat as well. And you'll find more information on who was involved, the study sponsors, and then all sorts of resources if you're trying to think about how you can put this data to work in your own work. So before I move on to newborn screening, I am happy to answer any questions about the burden study if they have arisen. And if not, I will keep on moving to the newborn screening. Okay. Well, I will keep going then. So I wanted to talk a little bit about newborn screening because I know that is an issue that many of you are working on and invested in seeing the future of newborn screening, the newborn screening system in the US modernized, improved, and ready to keep up with the advances that we are seeing and hope to see in the future for therapeutic development. So again, what is, just generally some newborn screening statistics, why we know it's so important. That newborn screening is maybe one of the biggest public health successes of our generation, and it truly is, screening every newborn for genetic, metabolic, hormonal, and other functional conditions that would not otherwise be apparent at birth. And newborn screening ultimately facilitates the timely delivery of those life-saving interventions, and prevents more disability and death that we know we can prevent through newborn screening. So newborn screening generally reaches 4 million newborns every year, but there's a very strict and complicated process for how your condition gets on the newborn screening panel. It is a state-controlled program, so I think it's important to note that all of the programs vary widely by state, which ultimately is another way to lead to, disparate health outcomes and health inequity. So you may have heard the stories where if you live in a state where you're bordering another state, and where you choose to go and have the baby might actually depend on whether the child has that chance to get the disease modifying therapy or not. Especially in some of the newer conditions which aren't implemented in every state. So SMA, XALD, Pompe, MPS, there are newer conditions where indeed all states are not screening for it. And so we know that your chances of success should not depend on where you live, and we have to do better than this. So one of the ways we try to work on that is by working on RUSP alignment legislation, which will require the state to screen for any disorder that's recommended by the federal RUSP. So that is the panel. If you're not familiar, that's the panel that is put out by it's endorsed by the HHS secretary, but it is recommended by a panel of experts, the Advisory Committee on Heritable Disorders in Newborn and Children, and it requires an extensive, nearly decade-long process of going through in evidence review, generating enough evidence to meet the requirements that that meet the newborn screening requirements. So do you have a disease modifying treatment? Is there an intervention? There are a number of technical test requirements. That is definitely not my area of expertise. And we do have a person on our team that can walk you through all of that if that's something you're interested in. But bottom line is, it's a federally recommended panel that then it requires each state to decide to implement the new test. And that puts so much burden on the backs of patient advocacy organizations who have just spent a decade plus trying to get enough evidence to have their condition added to the RUSP. Now they have to regroup and go state by state by state to work and advocate for new tests to be added to the panel. And so the legislation we work on requires the state, it's an automatic trigger for a timeline when that state needs to begin screening for the new RUSP disorders, and ensures that that funding is available moving forward to facilitate the addition of new screens and conditions, because ultimately there are, in many cases, new infrastructure that's needed, new resources, and even 2 years seems like a long time, but ultimately our public health labs do need that time to put in place all of the right processes and validate tests and build in that. So we feel like 2 years is a reasonable timeline. And we're really excited that RUSP alignment is catching on, and we are working in Maryland, Mississippi, and Iowa this year after passing bills in Ohio, North Carolina, and Georgia last year, and California and Florida, it previously were some of the states to kind of lay the groundwork for this. Both Maryland and Iowa are pending governor's signature, and Mississippi was enacted. And now that we have this critical bolus of states that have passed RUSP legislation, we are looking to how do we make sure we hold them accountable as new conditions are added. And the first new condition in a while was added a few months back. So now we'll have a great test case moving forward in the years to come. And then on the federal level, we of course focus on passing Newborn Screening Saves Lives Reauthorization Act and making sure the system has the right funding, as well as identifying policy solutions that are going to really enable the modernization of the newborn screening system. So one study we partnered on this year was released early this year or late in between December and January break over the holidays, was our Newborn Screening Modernization Consortium. And it is a great paper if you didn't find it and you're interested in newborn screening, outlining some of the areas that we need to focus on modernizing and moving forward into the next century. And the Newborn Screening Saves Lives Act is led by a coalition of wonderful advocacy organizations. And unfortunately, we have not yet been successful in reauthorizing the program, but we are absolutely still trying and pushing forward, because bottom line is the newborn screening program needs a authorization in the federal government to keep up with the needs that are happening daily. And we can't rely on discretionary advisory committees and funding. We need the authorization moving forward. So we're hopeful that we'll succeed there. But if you're interested in newborn screening as an issue, you're either just starting to get interested and think about what that means for your community, because you might have a therapy in development, or you've had a recent therapeutic approval, and it might make sense, for you to learn more about newborn screening process and how to navigate RUSP submission. We offer the newborn screening boot camp. We have the last 2 years have been virtual, but we are looking forward to hosting a hybrid event this year in October. Our date is going to be released soon, very soon, but it does align with the APHL Newborn Screening Symposium. So you can expect that it'll be sometime in October, aligned with that symposium, probably the day before, and it will be a hybrid event, but we're really looking forward to having some engagement in person, especially. And the boot camp is for everything from understanding the RUSP process. We have, you see in one of the pictures, Cynthia Powell, the co-chair of the advisory committee, kind of giving an overview of what changes are in place, or coming in the future, how to just, navigate interaction with the advisory committee, what are, the 101s, but this boot camp is also much more than the 101s. We had last year a whole discussion on how we enhance, diversity and leverage newborn screening to improve health equity, data, science, and how do we advance research using newborn screening. So there was really a wide variety of topics, and we're looking forward to getting those topics up for this year in 2022. So before I move on, I just want to check any newborn screening questions.
Hi, Jamie. Thank you for that informative part of your talk. Can you put different resources maybe at the end in the chat for advocates online? I caught that the date was October for the boot camp, or sometime in October, and suggested checking your website. But if there are any particular links specific to this effort, or educational materials, or anything that folks can use to learn, that would be great.
Definitely, I can do that.
Thank you.
Great. So the next thing I thought I would highlight for you, and especially patient advocacy groups that are really in the process of working with sponsors and others on therapy development early on, even the better, as you'll see in the resource itself. But we just recently released a project called the Guide to Patient Involvement in Rare Disease Therapy Development. And this came out of something we call the PFDD Guidance Compendium. As you may know, there have been a ton of efforts to improve the role of patient-focused drug development in the regulatory process, and to better incorporate patient experience data, patient preferences, patient priorities into how therapies are developed and reviewed. And we've made a lot of progress over the years, and there have been many guidances now coming out from the FDA on how do you incorporate this information. And so we wanted to take a step back and really look at understanding how patient-focused medical product development and those guidances can be applied to developing therapies for rare diseases. So this was done over a series of 4 workshops with a really multi-stakeholder collaborative that we considered the application of FDA guidances across the 4 life cycle stages of medical product development to identify those challenges and then those opportunities for how patient groups can get more involved and what sponsors can do as well. And that has led to the guide and the various resources online. And that's what you see here. And again, I can post the link straight to this in the chat as well. And I can send a list, Kristen, over to your team if that's something you want to distribute with the recording. But so what we did is that the 4 workshops were held between June and October of 2021. There were nearly 100 people involved. The discussions inform this guide, and it really connects to patient-focused medical product development policy to the challenges and opportunities present now. It's intended to be accessible, timely, and evergreen resource for stakeholders. And some of the features you'll see covered here, and it starts with an overview of patient-focused therapy development and FDA's leadership. So what is FDA doing, and what is the progress that's been made thus far? And then it's 8 cross-cutting topics once you get into it, and this came again from the workshops. These are the themes that really rose to the top. So, and where there were opportunities. So building relationships that last, documenting patient experience, defining what that unmet need is, determining and measuring outcomes, and more. You can read them all, but ultimately, within each of these 8 topics, you'll have action steps for both patient advocacy leaders as well as industry sponsors or non-industry, therapeutic developers, and opportunities where we can all collectively take action as well. You'll also, in the guide, and this is a sample layout for one of those topics, you'll also see at the end 112 relevant resources, including those guidances from FDA that would be relevant, and other organizations that have put out really worthwhile resources related to PFDD topics. And then workshop summaries to understand what was discussed at the workshops. So we're really proud of this, and we hope that it can be a tool and used, by other organizations, and welcome ongoing conversations. And our team, it can certainly answer any questions as you seek to apply it in your work as well. And it's just a little highlights of all of the resources you'll find on the website. All right, and then the next thing I wanted to talk about was ICD codes. And I said that I would come back to this while talking about the burden study, because one of the challenges we've seen is that, we can't track what's not in the data. And so unfortunately, ICD codes are used truly throughout the world by government agencies, researchers, insurance companies for billing purposes, to really track and report diseases, and of the more than 7,000 known rare diseases, very few of them have ICD codes established, and it leads to a whole host of problems, both in research and in access to care. In research, because we lack good ways to really track and identify the true burden of rare disease that is out there, and we lack the ability to diagnose, to connect your care to your diagnosis if you don't have an ICD code for that disease. And what that means is that it leads to access challenges, unnecessary hurdles for rare disease patients who are trying to access therapies that may not be associated with what code they were given, because they were given the next best code for a diagnosis since they did not have a code for their own disease. So with all of that said, the process for getting new codes is very complicated, intensive, and hard to navigate and slow. And so with that, we heard from the community that they were looking for help and how to obtain new codes. And so we engaged in, again, a number of conversations, interviews, groups, discussions to really identify what the barriers were, what is the process, how can we do this better for rare diseases, because it's another thing that falls on the back of patient advocacy organizations to manage. And we know that there's only so much that a dedicated group of whether it's parents or if you have professional staff, even, it's very challenging to navigate these processes, but also important. So we hope that we've made it a little bit easier for you. And again, this is just kind of highlighting the challenge we're trying to solve for, that we wanted to help even answer the basic question of, do you really need a new code or a revised code? And though there's a readiness assessment to help answer that question. So this is just the process we went through, and I don't need to spend too much time here. I think what matters is the resource that resulted. And so what you'll find on the website, icdcoderoadmap.org, is first a readiness assessment. So if you're just starting to think about this issue, you want to ask yourself, you know, is it what the biggest priority? Do we need this? Are you ready for it? And then you can learn a little bit more and disseminate online our little whiteboard video kind of explaining why we need ICD codes and what the guide is. And then the roadmap guide, again, to walk you through the process and give tips and share case studies of other organizations that have gone through this process. And then as patient advocacy organizations, if this is something you think others may be interested in, then we encourage you to share as you're able to, because this and the PFDD guide are only as good as we're able to disseminate and make sure that we get this information into the hands of those who could use them. So we are, again, very grateful to all of those who shared their needs and stories and case studies with us in this project. Let's see, just check the chat if there's any questions. I'm just going to fly through a couple of other resources or programs, and then happy to talk about anything else that I've skipped over. So wanted to make sure you knew we just launched a new website. We are also focused on accelerated approval, which is crucial for a number of rare diseases, especially those that are slowly progressing, difficult to measure outcomes, clinical outcomes. And so while this is primarily focused on understanding accelerated approval and the policy changes that may be needed, we are in the process of undertaking a study on accelerated approval in rare diseases and how accelerated approval has been applied across the board, so that we can identify evidence-driven policy reforms that can unleash the potential of accelerated approval for rare disease communities that have been unable to access it to this point, which we know is many. And then just a few rare disease advocacy opportunities. If you're not already connected with RDLA, RDLA is the advocacy arm of the EveryLife Foundation. So I work on our policy team, and I work on directly on our policy and evidence generation priorities. RDLA is really a platform for the community, and this is not to drive any one particular policy priority. This is to help you become advocates, better advocates, give you resources to use in your own advocacy and amplify your voice. So for example, with Rare Across America and Rare Disease Week, while we have some suggested asks that we put forward, the advisory committee of RDLA selects the policy issues that will be worked on by the advocates going and talking to members of Congress, and those can really cut across different rare disease issues. And then RDLA has monthly webinars where you, if your organization is working on a particular issue that is specific to your community, even, you can ask to have time on those webinars to present. You can ask for space in the newsletter for your issue. And then also we have a action center, which can host action alerts for you. So if you haven't yet invested in something like Voter Voice or the advocacy software that allows you to program templated messages for different elected officials and then send it out to your community, we offer that capability to advocacy organizations, to patient organizations, so that we can host that, give you a link, and you can use it without having to invest in that software yourself. If you serve individuals who are young adults, I really encourage you to connect them to the YAR program. It's just, it's probably my favorite program and that we do, because we get to interact with young adults, I believe ages 16 through 29, and they are just amazing. They're the inspiring advocates and stories, and they meet for a variety of different things. So right now there's a whole group of them going through a speakers training. So they're getting public speaking training, and we're setting them up with organizations to actually go out and speak about rare disease issues, share their stories. There was a leadership academy, in which that will happen again later this summer, where a select group is selected for a pretty intensive hands-on training program with young adult representatives to help prepare for more leadership roles in the rare disease community or in just public health in general. And there's more, and it's just one of the best and growing programs. So I really encourage you, if you know some young adults in your world, in the rare disease world, to get them connected to ER. And then I think just 2 more slides and I'm done. Just to flag, we started a new story bank, and we are really going to increase our sharing of the rare disease story in the many rare disease stories. And whether it's getting through a diagnostic Odyssey, whether it's dealing with discrimination or health inequalities, or regulatory challenges, there are stories in the community that are not shared far and wide, and we want to do our part in helping that. And so we started this story bank, and I'm really looking forward. We had over 100 submissions, I believe, in the first 2 months, and I just can't wait to share more of stories from the community, both online with members of Congress, with our partners, wherever you can think of. And we welcome submissions and suggestions on where stories can be shared, and if you want to be connected with different advocates. And then lastly, Community Congress, if you aren't familiar, is our network, our advisory network for patient advocacy organizations. And it also includes industry leaders and other rare disease stakeholders. We have 4 working groups, and this is how EveryLife really takes its direction on our policy priorities, our special projects and studies. And we meet quarterly. We have some ad hoc calls. And each group is led by a patient advocate and a member of industry. And it's really a remarkable environment of sharing and collaboration and supporting each other. And so if you're representing a patient organization that has some interest in rare disease policy issues, then we hope that you will join us. And then the last thing, just, I came to EveryLife from the Alpha-1 and the COPD foundations. I worked on rare lung disease and common lung disease for an individual named John Walsh, who used to be part of CPAGs, a part of the CPAG for a number of years, unfortunately passed away in 2017. And I always one of his most favorite sayings as we think about, collaboration and getting involved in things is that bottom line, if you're not at the table, you'll be on the menu. And really stuck with me because it guides a little bit of everything, we do and the approach we take, in that let's create big tables, let's bring people in, let's solve some of these big challenges together. And I know that's just by being part of the CPAG, that's what you all are doing too. So I keep John with me always, and thank you for having me, and welcome your questions.
Thank you, Jamie. That was fantastic. Lots of helpful information. One question that I do have is, I know many in the rare disease community during COVID had the opportunity to receive care from a physician, and many of us go out of state for our care without any issue. But after COVID has settled down, that was pulled back. Do you know about any efforts in that arena to expand telemedicine, or anything that we can do as advocates to advocate for that for our patients that we serve?
Yeah, absolutely. It's such I think the getting telehealth, I see it in, there's a whole number of flexibilities that were implemented related to telehealth during COVID. Some of it was just making it reimbursable in the first place, right? And making it so that you could get telehealth services in your home, whereas previously there was a limited number of services and you still had to go to a place like a doctor's office or wherever it was to get that telehealth service. So it was great for people in rural areas that needed to connect with an expert, with their doctor, but it wasn't truly telehealth the way we think of it now. Those things were changed. There's a bucket of issues that Congress can address. And the most recent thing they've done is extend some of those flexibilities to make it so that when the public health emergency ends, it won't automatically end because the flexibilities are tied to the public health emergency, which was just extended for 90 days. But in the appropriations bill they passed, that gives a buffer of 5 months after the public health emergency. The thinking is that they were likely trying to make it through the end of the year, roughly, to give themselves some more time to deal with it after the election. But bottom line is, unfortunately, the issue you brought up is likely not part of that. So there's some issues Congress can fix. There's some issues that they're just not going to fix because they're really rooted in state issues. So this is something that our Access Working Group has flagged as a priority and is going to be the topic of our next Access Working Group. You're not alone in thinking this, and we are starting to hear that feedback, that unfortunately, even if you could get telehealth still from a provider in your state, you're no longer being able to see, I worked with one advocate who lived in Vermont who had established care with an expert in Pennsylvania, totally changed the trajectory of her disease, helped really get it under control. Now no longer able to see that person via telehealth because simply the fact that she lives in Vermont. It doesn't make any sense. It's rooted in state licensure laws, professional scope of practice, and state licensure issues, and it's really not at all patient-centered and beneficial to the patient. So what the solutions are and the likelihood of actually solving the issue is a little bit unclear. It's going to require state-by-state efforts. We're looking at, with the working group, we're going to start looking at what are the things unique in the rare disease community, because again, we want to focus on who's our main audience and how can we suggest solutions that might be middle of the road. We're not proposing to change the entire system, but we're going to make sure that what happens is still going to allow that rare disease patient with no access to experts in her state or his state to get access to care via telehealth. So I wish I had a better answer for you because it is something we are starting to hear more and more about. And I know it's so hard. I grew up in Maine. My mom had a rare neurological disease, and it was very difficult for her she was not very mobile, and to get expert care, she would have had to go to Boston, but she ended up on Medicaid at towards the end of her life, and that wasn't possible, even in person. So there are active congressional efforts to deal with that piece, to simplify the process in Medicaid of getting access to care across state lines, but so far, we have not seen good solutions arise for telehealth yet.
Did I hear you say that the telehealth capability should be extended 5 months, but then after that?
Right now, they call it it's going to fall off a cliff, basically. So unless there are permanent fixes put in place, which I think the hope is that that's the case. It's an issue that both industry, the telehealth industry is really ramping up on, and patient advocacy groups are very much vested in as well. But it's something that's going to creep up on us if we don't pay close attention, because there is a possibility that the public health emergency order expires in July, and then that timer starts kicking. Yeah, it starts ticking.
Is it possible that some states are not following the extension of 5 months, or have you heard that?
Well, so that doesn't apply to the across state lines piece. So that's the issue, is that states had their own sort of public health orders and allowed that interstate care, cross state care. And many of those states have clawed that back now. And so there are areas where they have interstate compacts with other neighboring states, I believe, like DC, Maryland, Virginia, for example. It's one region, and it's easy to make that happen, but in many cases, that is not happening in other states now.
Thank you.
Yeah.
Anybody else have questions? Don't be shy.
And I'll give a shout out to Christina on the call because she's actually just came on as our co-chair of our public policy working group. So just special thanks to Christina and all of the work that she's doing with the UDNF and all of the help she's providing with EveryLife's work as well.